Welcome you all in today's presentation. Today our topic is Surviving Sepsis Campaign Guideline for Children. Management of sepsis and septic related organ dysfunction. There are wide discrepancy in protocols and practice worldwide. Especially in Bangladesh, the knowledge and practice regarding this is not uniform. And sometimes there is significant lack of awareness regarding recent updates. That's why I thought it's very important to discuss Surviving Sepsis Campaign Guideline for Children for the doctors working in the field of pediatric intensive care. I am Dr. M. Nurul Akhtar Hassan, Associate Professor and Pediatric Intensivist, Pediatric Cardiac ICU, National Heart Foundation Hospital and Research Institute, Dhaka. The Surviving Sepsis Campaign was first launched in 2002, which is a collaborative initiative of the European Society of Intensive Care Medicine, the International Sepsis Forum, and the Society of Critical Care Medicine. The objective of Surviving Sepsis Campaign was development and promulgation of evidence-based guidelines, facilitation of the application of knowledge derived from the clinical practice at bedside, to effect a 25% reduction in the relative risk of death from severe sepsis and septic shock. During the first meeting at Barcelona Declaration, there were segments which was focused, like awareness, diagnosis, treatment, education, counseling, and referral regarding sepsis and septic shock. The next year, a number of international, regional organizations, professional bodies from different continents endorsed this guideline and became sponsoring authority. And the first guideline came in 2004, Surviving Sepsis Campaign Guidelines for Management of Sepsis and Septic Shock. There were 6 hours bundles and 24 hours bundle. In 6 hours bundle, measurement of lactate level, obtain blood cultures prior to antibiotic, broad spectrum antibiotic within 3 hours of emergency admission and 1 hour of non-emergency admission. If hypotension or lactate more than 4 millimole per liter, then crystalloid bolus of 20 ml per kilo. If crystalloid boluses doesn't work, then add vasopressor to maintain a mean arterial blood pressure of more than 65 millimeter of mercury. The 65 cutoff point is for adult. If hypertension persists, then central venous pressure has to be measured and to be maintained by more than 8 millimeter of mercury, and to achieve a central venous oxygen saturation more than 70%. In 24 hours bundle, there are low dose steroid, recombinant human activated protein C, control of random blood sugar 70 to 150 milligram per dl, and in mechanically ventilated patients, maintaining plateau pressure of less than 30 centimeter of water in volume limit ventilation or in pressure limit ventilation to maintain a peak pressure of 30. In 2008, the second guideline came, Surviving Sepsis Campaign International Guideline for Management of Severe Sepsis and Septic Shock. And more organizations endorse this guideline, and these guidelines become universal and global. The 6 hours resuscitation was like previous, measurement of lactate level. Resuscitation goals include CVP of 8 to 12 millimeter of mercury, mean arterial blood pressure of more than 65 millimeter of mercury, urine output to maintain more than 0.5 ml per kilo per hour, and central venous oxygen saturation more than 70. If central venous oxygen saturation is not maintained, then consider further fluid boluses, transfuse packed cell if hematocrit is less than 30, and consider dobutamine. In 2012, the third guideline came. And there were some unique features, including more precise and clear diagnostic criteria for sepsis and septic shock. 6 and 24 hours becomes 3 and 12 hours, 6 hours bundle. And there were separate recommendations for pediatric patients, which was very important for us. In 3 hours bundle, lactate level measurements, obtain blood cultures prior to administration of antibiotic, administer broad spectrum antibiotic, Administer 30 ml per kilo crystalloid for hypotension, or if lactate is more than 4 millimole per liter. In 6 hours bundle, vasopressor for hypotension not responding to fluid boluses to maintain mean arterial blood pressure. If hypotension persists despite volume resuscitation, that is septic shock, or initial lactate more than 4 millimole per liter, then central venous pressure measurement and central venous oxygen saturation measurement, and remeasure lactate level if initially high. And the target for quantitative resuscitation include, in this guideline, CVP more than 8, mixed venous oxygen saturation or central venous oxygen saturation more than 70, and lactate normalization. In the same year, there were another guideline, the Surviving Sepsis Campaign Guideline 2012, update for emergency physician. I am not going in detail. In 2016, the fourth guideline came, and 3 hours bundle became 1 hour bundle, because it was found the earlier the treatment started, the better the result. So at 1 hour bundle, measurement of lactate and remeasure if initially it is high. Obtain bulk culture prior to administration of antibiotic, administer broad spectrum antibiotic, rapid administration of 30 ml per kilo fluid boluses, and apply vasopressor if hypotension persists. And this is the fifth guideline came this year. Before going into this guideline, I would like to request you to go through the fourth guideline published in 2016, especially pediatric part, because there was a separate pediatric part which is very elaborate and very helpful. So this year, Surviving Sepsis Campaign International Guideline for the management of septic shock and sepsis related organ dysfunction in children came for the first time. So today I have discussed in detail regarding the recommendations on, because there are around 80 recommendations. It is an article of 56 pages and very difficult to discuss in a short period of time. So I have discussed only recommendations, but the explanation regarding this recommendation will not be possible to discuss today. So I'd like to request you to go through the article for detail and explanations. Scope of patients: 37-week gestation at birth to 18 years old with severe sepsis or septic shock. That means premature neonates are not included in this guideline. Children who present as acutely unwell, systematic screening for timely recognition of septic shock and other sepsis related organ dysfunction is mandatory in all sick patients. To implement a protocol guideline for management of children with septic shock or sepsis related organ dysfunction. Antibiotic: to obtain blood cultures prior to initiating antimicrobial therapy. In children with septic shock, antimicrobial therapy as soon as possible within 1 hour of recognition. In children with sepsis related organ dysfunction without shock, antimicrobial therapy has to be started within 3 hours. That means if there is shock, treatment to be started within 1 hour. If no shock, then 3 hours. But treatment should not be delayed only for sending blood culture. So if there is delay in blood culture, antibiotic should be started. Empiric broad spectrum antibiotic with one or more antimicrobial coverage to be started. Once the pathogens and sensitivities are available, narrowing empiric antimicrobial therapy coverage. That means when the culture sensitivity is available and it is not necessary to continue the empiric antibiotic, narrowing of or de-escalation of antimicrobial therapy is recommended. If no pathogen is identified, narrowing or stopping empiric antimicrobial therapy according to clinical presentation, site of infection, host risk factor, and adequacy of clinical improvement. So treatment should not be continued only as we started the antibiotic. In children without immunocompromise and without high risk of multidrug resistant pathogen, Surviving Sepsis Campaign suggests against the routine use of empiric multiple antimicrobial antigen directed against the same pathogen for the purpose of synergy. In children with immunocompromise or at risk of multi-drug resistant sepsis, suggestion is to continue multi-drug resistant. That means if there is no immunocompromise or no risk of multi-drug resistant sepsis, then single drug empiric antibiotic therapy can be started. Daily assessment in terms of clinical and laboratory assessment for de-escalation of antimicrobial therapy. There is no 5-day, 7-day, 14-day, 10-day course. That is actually myth. Treatment has to be discontinued as per patient's clinical response and laboratory features. Source control. Removal of intravascular access device that are confirmed to be the source of sepsis or septic shock after other vascular access has been established. That means if sepsis is suspected for the in situ vascular lines, then after ensuring another vascular lines, old line should be removed. Fluid therapy. Fluid therapy depends on availability of intensive care. If there is intensive care available, then 10 ml per kilo fluid boluses in each time, maximum total 40 to 60 ml per kilo bolus can be given over 1 hour. But at the same time, you must follow clinical markers of cardiac output and discontinue if signs of fluid overload develops. So if there is hepatomegaly or basal crepes, then large amount of fluid bolus to be avoided. If intensive care facility is not available, then if no hypertension, then no bolus fluid, only maintenance. And if hypertension, then up to 40 ml per kilo bolus, each time 10 to 20 ml per kilo bolus over 1 hour. At the same time, we have to follow clinical markers of cardiac output and discontinue if there is signs of fluid overload. Crystalloids are recommended rather than albumin for the initial resuscitation of children with septic shock or other sepsis related organ dysfunction. Fluid of choice include balanced buffered crystalloid rather than normal saline, because normal saline was found causing hyperchloremic metabolic acidosis if large normal saline bolus is given. Balanced buffered crystalloid includes plasma light, Ringer solution, Hartmann solution, etc. Plasma light is not available in Bangladesh. Synthetic crystalloid like starch gelatin should not be used. Hemodynamic monitoring. Enough evidence were lacking to provide the recommendation about target mean arterial blood pressure. However, most of the centers practice mean arterial pressure in between 5th and 50th centile or greater than 50th centile for age. Guidelines suggested not to use bedside clinical signs in isolation to categorize septic shock in children as warm or cold shock. So on the basis of only clinical parameters, it should not be classified. Using advanced hemodynamic variables were suggested when available, in addition to bedside clinical variables to guide the resuscitation of children. Using trends in blood lactate level were suggested in addition to clinical assessment. Vasoactive medication suggests using either epinephrine or norepinephrine rather than dopamine in children with septic shock. But the guideline was unable to issue recommendation for a specific first-line vasoactive infusion for children. So norepinephrine or epinephrine, anyone can be started earlier, but not dopamine. For those who require high-dose catecholamine, it was suggested to add vasopressin or further titration of catecholamine. But for vasopressin, patient needs central venous catheter. Guideline was unable to issue a recommendation about adding an inodilator like dobutamine, milrinone, levosimendan in children with septic shock and cardiac dysfunction despite other vasoactive agents. However, in practice, sometimes inodilators are used despite other vasoactive agents. So in practice, we prefer dobutamine or milrinone if there is shock with ventricular dysfunction. Ventilation. Children with fluid refractory catecholamine resistant septic shock without respiratory failure usually intubated at most of the centers, but the guideline was unable to issue a recommendation. A trial of non-invasive mechanical ventilation was suggested in children with sepsis-induced pediatric ARDS without a clear indication of intubation and who are responding to initial therapy. So if there is no strong indication of intubation or if patient is improving after initial management, then a non-invasive ventilation can be tried before intubation. Suggestion in sepsis-induced ARDS using a high positive end expiratory pressure, even 10 to 15 centimeter of water. A trial of prone positioning 12 to 18 hours per day if there is significant hypoxemia or refractory hypoxemia, and use of neuromuscular blocking agent if there is significant hypoxemia and difficulty in ventilation. The guideline was unable to issue a recommendation to use high frequency ventilation versus conventional ventilation in children with sepsis-induced ARDS. Corticosteroid. Guideline suggests again using IV hydrocortisone to treat children with septic shock if fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. Either IV hydrocortisone or no hydrocortisone may be used if adequate fluid resuscitation and vasopressor therapy are not able to restore hemodynamic stability. So there is no clear guideline or no strong evidence in favor of or in against hydrocortisone. Endocrine and metabolic. Recommendation against insulin therapy to maintain a blood glucose target at or below 140 mg per dl. Guideline was unable to issue a recommendation for a target range of blood glucose in children with septic shock or other sepsis-related organ dysfunction. However, in practice, there are consensus to target blood glucose level below 180 mg per dl. There is no recommendation to target normal blood calcium level. However, in practice, we often target normal calcium levels for children with sepsis or septic shock who are requiring vasoactive infusion. Nutrition. No recommendation was suggested regarding feeding. However, in practice, there is a preference to commence early enteral feeding within 48 hours of admission who have no contraindication to enteral nutrition, and to increase enteral nutrition in a stepwise fashion until nutritional goals are met. Guidelines suggest not withholding enteral feeding solely on the basis of vasoactive inotropic medication administration. Guidelines suggest enteral nutrition as the preferred method of feeding. Parenteral nutrition may be withheld in the first 7 days of PICU admission in children with septic shock or other sepsis-related organ dysfunction. Also suggested administering enteral feeds through a gastric tube rather than a post-pyloric feeding. Guidelines suggest against supplementation with specialized lipid emulsion, routine use of prokinetic agent for the treatment of feeding intolerance, use of selenium, glutamine supplementation, arginine, zinc supplementation, ascorbic acid, thiamine and vitamin D supplementation. Blood products. Suggested against transfusion of RBCs if the blood hemoglobin concentration is more than 7 gram per dl in hemodynamically stabilized child. Guideline could not make a recommendation regarding hemoglobin transfusion threshold for critically ill children with unstable septic shock. However, in practice, many centers transfused if hemoglobin level is less than 8 in hemodynamically unstable child. Also suggested against prophylactic platelet transfusion based on platelet level in non-bleeding children with thrombocytopenia. So only for thrombocytopenia, platelet transfusion should not be given even if it is 10,000. Same is for fresh frozen plasma. Plasma should not be transfused in non-bleeding children only to correct coagulation abnormalities. Plasma exchange, renal replacement therapy and ECMO. Suggested against using plasma exchange in children without thrombocytopenia associated multiple organ dysfunction. So plasma exchange can be done in disseminated in vascular coagulation patients. Suggested using renal replacement therapy to prevent or to treat volume overload in children unresponsive to fluid restriction and diuretic therapy. Because it was found fluid overload is another condition which causes directly adverse outcome. Suggested using venovenous ECMO in children with sepsis-induced ARDS and refractory hypoxemia, and veno-arterial ECMO in a rescue therapy with septic shock refractory to other treatment. Immunoglobulin. Suggested against the routine use of IV immunoglobulin in children with septic shock. Prophylaxis. Suggested against the routine use of stress ulcer prophylaxis in critically ill children. However, in mechanically ventilated patient, to prevent ventilator-associated pneumonia, there is a recommendation to continue peptic ulcer prophylaxis. So, patient's benefit should be considered. Suggested against routine deep vein thrombosis prophylaxis in critically ill children, but potential benefits may outweigh risk and cost in specific population. So, in summary, there are numbers of recommendations in management of pediatric sepsis and septic-related organ dysfunction. Some recommendations are evolving and may change over time. For further detailed explanation of the recommendations, please go through the article which is available online free. Thank you. If you find this beneficial for you, please give a thumbs up and subscribe the channel to get notification of future videos.